Usually when we talk about a medical diagnosis, there's this underlying expectation of precision.
Oh, yeah, like it feels like engineering.
Exactly. Like if you break your arm, you go in, they take an x-ray, and there's that jagged white line on the monitor.
Right, right. It's binary, broken or not broken.
Yeah, and the doctor just points at it and says, there it is.
Which is incredibly comforting for a patient. I mean, being able to look at a screen and see the exact structural failure that's causing your pain completely validates your experience.
Totally. But then you step into the world of neurodevelopment and chronic pain, specifically in women's health, and, well, suddenly that x-ray machine is just totally useless.
Yeah, it really is.
We're looking at a diagnostic landscape that is entirely invisible to the naked eye. And today, we are going to look at a condition where the ultimate diagnostic instrument isn't some, multi-million-dollar MRI machine.
Right.
It's basically a common household item, a simple cotton-tipped swab.
Which, I mean, that sounds completely counterintuitive for a complex neurological issue.
Right.
But that cotton swab is arguably one of the most vital, high-precision tools we have in this specific field of medicine.
Well, welcome to today's deep dive. We are looking at a stack of incredibly detailed sources today to unravel all of this for you.
We really are. We've got a lot of ground to cover.
Yeah, we've pulled clinical guidelines from the British Association for Sexual Health and HIV, terminology consensuses from the International Society for the Study of Vulvovaginal Disease, along with a whole array of peer-reviewed medical journals and clinical trial data.
And our mission today is to decode exactly how clinicians use that simple cotton swab test to precisely map out something called localized versus generalized vestibular hyperalgesia.
Right.
And crucially, why mapping out this invisible pain is basically the ultimate key to unlocking effective, targeted treatment for patients.
Okay, but before we even get to the swab, we really need to understand the landscape of the condition itself, right? Like why it's historically been so incredibly elusive and frankly maddening for the people experiencing it.
Absolutely, because you can't map a territory if you don't even know what continent you're on.
Exactly. So the condition we are looking at is called vulvodynia.
Right, and according to the international consensus in our sources, vulvodynia is defined as chronic vulvar discomfort.
And patients usually describe it as what? Like a severe burning?
Yeah, severe burning, stinging, stabbing, or even just this intense raw sensation. And to meet the clinical criteria, this pain has to last for at least 3 months.
Okay, 3 months.
But the defining characteristic, the reason it's so elusive, is that it happens without any visually identifiable cause.
Which means a patient comes in, they're experiencing this agonizing, knife-like pain. But when the clinician looks, the tissue appears completely healthy.
Perfectly healthy.
There's no rash, no lesion, no swelling. Basically, there's no jagged white line on the x-ray.
And we really have to pause and consider the psychological toll of that.
Oh, I can't even imagine.
Right. You sit there in a paper gown, you are in excruciating pain. And a medical professional looks at you and essentially says, well, everything looks perfectly normal.
Wow.
So for decades, because the tissue looked healthy, many patients were simply told the pain was psychosomatic, like it was all in their heads.
Which is just so frustrating. And that leads to vulvodynia being what the medical community calls a diagnosis of exclusion.
Exactly. The doctors have to systematically rule out every other possible visible or testable cause before they can even arrive at vulvodynia as a diagnosis.
So they're testing for, standard infections first.
Yeah, recurrent candidiasis or thrush, things like that. Then they run biopsies for inflammatory dermatoses like lichen sclerosis or lichen planus.
Right.
They even have to exclude neoplastic disorders like squamous cell carcinoma and specific neurological issues like herpes neuralgia.
So a patient might undergo months or even, years of invasive testing only for every single result to just come back negative.
Exactly.
And only when all those visible culprits are cleared and the pain is still there do we enter the territory of vulvodynia.
That's right.
And within this diagnosis, our sources highlight 2 major concepts that define the patient's daily reality, which are hyperalgesia and allodynia.
Right. So hyperalgesia is an extreme heightened sensitivity to a painful stimulus. Something that should hurt a little hurts a lot.
Okay, that makes sense.
But allodynia is arguably the more disruptive symptom here.
Why is that?
Because allodynia is a painful response to completely non-painful stimulus.
Oh, wow. So we're talking about experiencing agonizing pain from, wearing tight jeans or inserting a tampon or even just sitting down at a desk for a prolonged period.
Yeah, exactly, which is a classic hallmark of neuropathic pain. The biological hardware, the skin and the tissue is perfectly intact, But the software processing those physical sensations is fundamentally altering the input.
Okay, let's unpack this. It sounds exactly like a faulty home security system, where the sensors are so dialed up that just a single leaf blowing against the living room window sets off the whole break-in alarm.
That is a perfect analogy, actually.
Like the window isn't broken, there is no intruder, but the sirens are blaring at full volume inside the house anyway.
Yes, the biological sensors are interpreting a gentle breeze as a 5-alarm fire. And you can inspect that window all day long, and it will look structurally perfect.
Right.
So you need a specialized tool to test the sensors themselves, to pinpoint exactly where the faulty alarm is actually originating from.
Which brings us to the star of the show, the cotton swab.
The swab, yes.
Since there's no visible rash to guide the doctor to the source of that faulty alarm, they rely on this test. And reading through these clinical guidelines, the procedure itself is meticulously choreographed.
It has to be. You're dealing with a patient who is already living in a state of chronic pain, and you're trying to deliberately elicit a response to map the boundaries of that pain. So it requires this incredibly methodical approach.
So the clinician starts by taking a moistened cotton swab and gently pressing it on a completely neutral area, right? Like the patient's inner thigh.
Exactly. That establishes a baseline. It allows the patient's brain to register the physical sensation of the swab on healthy, non-sensitized skin.
Oh, okay.
Yeah, it calibrates their expectations so they can consciously recognize, okay, this just feels like a soft, damp touch.
That makes a lot of sense. Then the clinician moves medially. Like they test the labia majora, the clitoral hood, the labia minora, and ultimately they reach the vulvar vestibule, which is the tissue directly surrounding the entrance to the vagina.
Right.
And this is where the mapping becomes incredibly precise. They use this clock face method, so the clinician will gently press the swab at specific positions usually, like 2, 4, 6, 8, 10, and 12 o'clock around the vestibule.
And those correspond to very specific anatomical landmarks.
Oh, really? Like what?
Well, the Skene's glands are near the top at 2 and 10 o'clock. The Bartholin's glands are down at 4 and 8. And the posterior fourchette is at 6 o'clock.
Got it.
So as the clinician touches each point, the patient is asked to rate the pain on a numeric rating scale from 0 to 10.
Okay, wait, I have to jump in here.
Sure.
Because if we just establish that this patient has severe allodynia, where just sitting down in a chair sends them into agony, isn't taking a cotton swab directly to the most sensitive areas of the vestibule, basically just torturing them.
It sounds like it, yeah.
Like, how is intentionally triggering that alarm productive at all?
Well, clinicians are acutely aware of the wince factor here.
Yeah.
They know it's daunting. But the procedure is done with extreme care.
Oh.
The swab is heavily moistened to reduce any friction, and the clinician communicates through every single step, allowing the patient to stop at any time. It's not done to induce suffering.
Right.
It's done because it yields remarkably high diagnostic accuracy that fundamentally alters the patient's future.
Because the swab test has an 85% positive predictive value for confirming vestibulodynia, according to the data.
Right, meaning if the test elicits pain at those specific clock points, there's an 85% certainty that localized vestibulodynia is the correct diagnosis.
Wow.
Without that map, you are flying blind in treating the pain. It transforms this objective feeling of generalized agony into an objective, treatable grid.
And the distinction this map creates is basically the entire focus of our deep dive today.
Yes, it is.
Because if the patient reports that severe pain, but it's strictly localized to those specific clock points within the vestibule, the diagnosis is localized provoked vestibulodynia, or LPV.
Exactly.
But if that severe pain radiates beyond the vestibule, like extending to the inner thighs or encompassing the whole vulvar region, the diagnosis shifts entirely. It becomes generalized vulvodynia.
And that differential is everything. It changes the whole game.
So, okay, we have this map. The swab has drawn a ring of fire at, say, the 4 o'clock and 6 o'clock positions. The patient feels a 9 out of 10 burning pain there, but 0 pain on their thigh.
Right.
Now we need to look under the microscope. What physical changes has that tiny cotton swab actually detected beneath the skin that looks so perfectly healthy?
Well, histopathologic findings, basically looking at the tissue at a cellular level, have completely overturned the old idea that this pain is psychological.
Thank goodness.
Right. The sources outline 2 landmark findings in localized provoked vestibulodynia, which are chronic neuroinflammatory changes, and hyperinnervation.
Okay, hyperinnervation literally means an overgrowth of nerve fibers, right?
Yes, exactly. And the mechanism behind how this happens is this wild cascade effect. It actually starts with mast cells.
Mast cells, those are the immune cells that reside in your connective tissues, yeah.
Yeah, normally they respond to inflammation or allergies by releasing histamines. But in patients with LPV, there is a significant abnormal increase in the number of mast cells right there in the vestibular tissue.
Interesting.
And in this specific case, when these mast cells degrade, they release an enzyme called heparinase.
Okay, heparin, what does that do?
Heparinase has a very specific destructive function. It breaks down the surrounding connective tissue,
Oh, wow. So the structural integrity of the tissue barrier is compromised.
completely compromised.
Yeah.
And because that connective tissue barrier is eaten away by the heparinase, a specific type of nerve fiber called C-afferent nociceptors.
The primary pain-sensing nerves.
Right. Those nociceptors are able to wildly proliferate. They literally grow and penetrate straight through the basal membrane, reaching all the way up to the surface epithelium.
Here's where it gets really interesting. So basically, the heparinase is essentially breaking up the concrete of a sidewalk, right?
Yeah.
Allowing the roots of a weed, those pain-sensing nerve fibers, to burst right through to the surface where they absolutely shouldn't be.
That is exactly what's happening. And because those weeds are now exposed at the very surface of the skin, when the moistened cotton swab touches that area, it isn't touching normal skin cells.
It's directly stimulating a dense, overgrown cluster of exposed raw nerves.
Yes, which completely explains the allodynia.
Wow. So the security system isn't just misfiring. It's like someone has ripped the internal wiring out of the wall and just laid it bare on the living room floor. If you brush against it, it starks.
Exactly. But this localized peripheral inflammation doesn't just stay local forever. This is a crucial point.
Right.
If this wiring fires constantly over a long period, it can eventually trigger something called central sensitization.
Yeah. Our sources heavily emphasized central sensitization, and this seems like a massive turning point in the condition.
It is. Central sensitization occurs when the constant, relentless bombardment of pain signals from those overgrown nerves actually alters how the brain and the spinal cord process pain globally.
So the whole system gets hijacked.
Pretty much. The central nervous system gets so used to receiving high alert danger signals from the vestibule that it becomes hyperreactive across the board. The threshold for what the brain considers painful just drops dramatically.
So the brain essentially gets stuck in a loop, basically hallucinating emergencies everywhere. And this explains a major clinical mystery, right? Like why vulvodynia is so frequently comorbid with other seemingly unrelated chronic pain conditions like fibromyalgia, irritable bowel syndrome, and interstitial cystitis.
Exactly. Because if the central processor, the brain, and spinal cord is sensitized, the patient starts experiencing pain amplification across multiple body systems.
Right.
So a normal digestive cramp is suddenly registered by the brain as agonizing IBS. The original source of the pain was localized, but the software processing it has become universally corrupted.
Which is just wild.
Yeah.
If we look at this biological reality, the heparinase, the nerve proliferation, the central sensitization, I mean, it definitively proves the pain is physical.
Absolutely.
It's a structural cellular abnormality.
It fundamentally validates the patient's experience. It proves unequivocally that the pain is real and rooted in biology.
Which has to be a huge relief for anyone who's been bouncing from doctor to doctor for years being told they're crazy.
Oh, absolutely.
But that brings us to the ultimate question for the patient sitting in the exam room right now. We have the swabs map. We know the biology of the weeds breaking through the sidewalk.
Right.
So how does this exact mapping directly alter the clinical outcome? Like, what is the so what of the cotton swab test?
The so what is that the map dictates entirely different therapeutic blueprints.
Okay.
The treatment for localized pain is fundamentally different from the treatment for generalized pain. So let's start with localized provoked vestibulodynia.
Okay, so the swab mapped the pain to specific clock points. What do we do about those specific weeds?
Because the pain is localized, the treatments can be highly targeted. The first line of defense is often topical lidocaine, usually like a 2 to 5% ointment, and it's applied directly to the specific vestibular points mapped by the swab.
But wait, lidocaine is just a numbing agent, right?
Right, that's what people think.
How does that actually fix the overgrowth of nerves? Doesn't it just mask the pain for a few hours?
Yeah, that's a super common misconception. But the goal here isn't just temporary relief.
Oh, really?
No. Lidocaine works by blocking sodium channels in the nerve endings, which stops them from transmitting action potentials, basically pain signals up to the brain.
Okay.
By continually applying lidocaine over a period of weeks or months, you are artificially interrupting that constant feedback loop,
Oh, I see.
right? And without that constant firing, the nerves stop overexpressing pain receptors. And in many cases, they naturally start to downgrade or just die back.
So you're starving the weeds of the signals they need to thrive.
Exactly.
That makes so much sense. It's not a Band-Aid. It's literally retraining the hardware.
Yes.
And the sources also highlight localized pelvic floor physical therapy. And this isn't just, a doctor telling a patient to do Kegels, is it?
Oh, not at all. The physical therapist uses the Swab map to assess specific pelvic muscles for hypertonicity, which is extreme tightness.
Right.
Specifically, they're looking at muscles like the levator ani and the obturator internus.
And these are the muscles that basically form the hammock of the pelvic floor, right?
Oh.
Supporting the pelvic organs.
Correct. And because the body is in severe pain from the vestibule, it reflexively guards itself. The pelvic floor muscles tense up to protect the area.
Just a natural defense mechanism.
Right. But that constant involuntary tension cuts off healthy blood flow and creates a secondary source of lactic acid buildup and muscle pain.
Oh, wow.
So the physical therapy helps release that specific localized guarding, which restores oxygen and blood flow to the tissue.
Okay, but what if those medical management techniques fail? Like the lidocaine isn't retraining the nerves, the physical therapy isn't enough? Because for localized pain, the guidelines introduce a surgical option, right?
They do. And this is where the precision of the Swab map becomes absolutely paramount. If localized pain is refractory, meaning it completely resists treatment, a vestibulectomy may be offered.
And a vestibulectomy is the surgical excision, basically the actual cutting away of the specific painful vestibular tissue that was marked out by the swab.
Yes.
The sources mention the surgeon usually excises the tissue along what's known as Hart's line.
Yeah, Hart's line is basically the anatomical boundary, where the outer vulvar skin meets the inner mucosal tissue of the vestibule.
Okay.
The surgeon is using the Swab's map to literally cut the weeds out of the concrete, removing the hyperinnervated tissue entirely.
But that surgical option is entirely dependent on the swab test confirming localized pain, right?
Well, 100%.
Because if the swab mapped generalized pain, if the pain radiated to the thighs or the whole vulvar region, the guidelines are crystal clear. Surgery is never recommended.
Never. Because if the pain is generalized, it strongly indicates that central sensitization is the primary driver, or that it's a systemic neuropathic issue.
Right.
Cutting out a small piece of vestibular tissue at 6 o'clock won't stop the pain, because the pain isn't originating from those specific nerve endings anymore. The alarm system itself is corrupted.
So surgery would not only fail to cure the pain, it could potentially introduce new trauma that the sensitized brain would just amplify even more.
Exactly. It would be counterproductive.
So what does this mean for the patient whose swab map showed generalized pain? How do you treat that?
The focus shifts entirely to treating systemic neuropathic pain. Clinicians will utilize oral medications that alter nerve signaling globally.
Like what kind of medications?
Well, we're looking at medications like amitriptyline, which is traditionally known as a tricyclic antidepressant.
Which, that might sound super alarming to a patient who has spent years trying to prove their pain isn't psychological. Like, you're giving me an antidepressant for my physical pain.
Exactly. And that requires very careful explanation by the clinician.
I bet.
At the lower doses used for pain management, amitriptyline isn't acting as an antidepressant. It actually works by inhibiting the reuptake of neurotransmitters like serotonin and norepinephrine in the descending pain pathways of the spinal cord.
So it essentially turns down the volume dial on the central nervous system, dampening those hallucinated pain signals.
That's right. They also use anticonvulsants like extended-release gabapentin, which stabilizes electrical activity in the nerves globally. And they heavily incorporate cognitive behavioral therapy to help the patient manage the chronic pain cycle and consciously calm the central nervous system.
See, precision diagnostics save patients from undergoing invasive, potentially painful, and ultimately useless treatments.
Yes.
Imagine having a highly sensitive excision surgery for what is actually a generalized central nervous system issue.
It would be devastating.
Truly, and the cotton swab prevents that. It acts as like the ultimate sorting hat for the clinician, ensuring patients don't spend years stuck in a cycle of failed treatments just because they were miscategorized from day one.
It's really incredible how much clarity can come from something so simple.
It really is. We started today looking at the frustration of an invisible condition.
Yeah.
a diagnosis of exclusion where the tissue looks perfectly healthy but the internal alarms are just blaring.
Yeah.
And we've seen how a simple cotton swab, methodically mapping a clock face, can unearth a biological reality of enzyme degradation and nerve proliferation.
It bridges the massive gap between what the patient feels and what the clinician can actually treat. It moves vulvodynia from this frustrating mystery to a manageable structural condition with very clear therapeutic pathways.
And for you listening, understanding these tools really empowers you. When you go into a clinic and you know how a doctor is testing you and why they are touching a swab to a specific clock point on your body, you become an active participant in your own healthcare.
Absolutely.
You aren't just a passive bystander hoping they figure it out. You are actively helping them draw the map.
You're providing the exact data they need to navigate your treatment blueprint. It's a team effort.
But as we wrap up this deep dive, there is one final, lingering detail hidden in the clinical sources that we want to leave you with today.
Well, this is a big one.
Yeah, it's something for you to mull over that extends just a bit beyond the nerve fibers we've discussed today. Because the sources mention that drops in estrogen can actually decrease the mechanical pain threshold in the vestibular mucosa and trigger secondary vestibulodynia.
Right. Estrogen plays a massive role in maintaining the health and elasticity of that specific connective tissue.
And what causes those estrogen drops? I mean, sometimes it's a natural life progression, like going through menopause, but very often it is caused by taking combined oral contraceptives.
Birth control pill,
Right.
which is an incredibly ubiquitous medication.
Yeah.
Millions of people take it.
Exactly. Which leaves us with this final thought. If the daily hormonal medications we take can unknowingly rewire the physical density of our nerve fibers, altering our tissue so drastically that it interprets the touch of a gentle cotton swab as a burning knife, what other invisible changes are happening in our body's hardware right now that we're simply writing off as being all in our heads?
It's definitely something to think about.
Something to think about the next time you assume your internal X-ray is clean. We'll see you on the next deep dive.